Hi, I'm Jessica and I'm a speech-language pathology student.
Hi, I'm Demetra and I'm also a speech-language pathology student.
And today we're here to talk about
laryngectomy.
A laryngectomy. Aphonia caused by a complete laryngectomy. This is an integral part of voicing. The larynx is composed of the thyroid, cricoid, and arytenoid cartilages. Take a walk with me. There are three main categories of voice disorders: functional, organic, and neurological. Functional voice disorders is a change in the behavior of the larynx. Organic voice disorders is a change in the physical condition of the larynx, as in cancer, polyps, or something like that. And neurological voice disorders is an impairment of the central nervous system or peripheral nervous system that then therefore changes the larynx as well.
Aphonia is the most severe speech disorder. There are two causes, psychological and physical. Psychological cause is the client's refusal to speak. Physiological causes include the absence of the vocal fold in the case of a laryngectomy, stiffness of vocal folds, and the inability of the vocal folds to approximate. A seemingly healthy 63-year-old male and horse auctioneer was a 2-pack-a-day smoker.
Now, well, hello there. I'm Mr. S. I'm a 63-year-old equine auctioneer who smokes 2 packs a day.
Welcome to the auction. We have the Chevron main horse. Looks like a cow, tastes like a cow as well. What you got? What you got? We have a bid. What was that? $2,000.
Due to persistent hoarseness, he went to get checked out at a clinic.
Listening to the vocal quality of an individual is a good preliminary indicator of the presence or absence of a vocal disorder. The hoarseness of Mr. S's vocal quality indicated that there were both functional and organic causes of his voice disorder. The functional causes of Mr. S's persistent hoarseness could be logically attributed to his excessive vocal abuse needed by his profession. The organic causes, however, were much less apparent and needed to be examined. Hi, Mr. S. Thank you for coming in today.
Thank you for having me. There you go.
Well, to address what we were talking about last time about your larynx, we've actually discovered a smooth mass on your right vocal fold, and biopsy has determined that it's a squamous cell mucosal hyperplasia keratosis. Do you know what that is? Well, it's an abnormal growth of epithelial cells in response to laryngeal trauma. So in your case, it was probably caused by your cigarette smoking and the hyperfunction of your larynx in your job. But actually, the mass has grown so much from your right vocal fold that it grew into the glottal space, so that's why your vocal folds aren't abducting. And that's the cause of your hoarseness.
Mr. S's hoarseness persisted over the years, and he underwent several treatments. Some of these included laser procedures to remove the recurrent swelling on the right vocal fold, anti-reflux medication, and steroids to treat the dysphonia. Unfortunately, 2 years later, Mr. S developed dyspnea, or difficulty breathing, as well as chronic hoarseness. These two suggest that the mass on his right vocal fold remained, and it impeded his airflow. There was a problem.
Investigation into that smooth mass has concluded that it's actually developed into a carcinoma, which is a cancerous growth on your vocal fold. And it's substantial enough to impede airflow, so that's why your hoarseness has grown. You become more hoarse now. And this discovery is going to have to require immediate research by us.
The larynx houses the main speech mechanism, the vocal folds. When the larynx is deemed unfit for the well-being of the patient, the larynx needs to be removed, resulting in a laryngectomy, or a complete removal of the larynx. A laryngectomy results in the most severe voice disorder, aphonia.
Due to the severity of Mr. S's cancer, his initial treatment was a laryngectomy. After crossing over from the initial growth on his right vocal fold, the cancerous presence was now detected in both vocal folds as well as the subglottal space. As a result of this invasion, the muscles and cartilages of Mr. S's larynx, as well as the hyoid bone and the superiormost rings of his trachea, were removed. The remaining portion of the trachea was connected to the external environment via a hole in his throat, the stoma, to enable respiration. Consequently, this procedure resulted in aphonia. Now that your surgery is over, we can start rehabilitation with the otolaryngologist and myself, the speech-language pathologist, to recover from your aphonia, and then we can begin the road back to verbal communication. Types of treatment options for a laryngectomy: an electrolarynx, esophageal speech, and tracheoesophageal speech. So initial therapy will focus on producing intelligible and functional alaryngeal speech with an electrolarynx. Do you know what an electrolarynx is? Electrolarynx electrolarynx is a mechanical vibrator that serves as an artificial larynx. The electrolarynx is placed on the neck of the patient in the spot that produces the most sound. When an electrolarynx vibrates, it produces waves that travels up the throat, and the sound travels through the oral cavity and resonates into the resonators and articulators.
We'll begin with manipulating your articulation and rate of speech with the electrolarynx, because that's one of the fastest routes back to functional communication. You can use an electrolarynx with very little training, but we're going to be working on that with you. You can use an oral adapter with it as well. That way we can ease the pressure on the delicate tissue of your neck, since it's so close to post-surgery, to minimize the soreness until you can use actual neck placement.
Hi, Mrs. S. How are you doing today?
I'm good, doll. How are you?
I'm doing pretty well. So I heard that you had some concerns with the electrolaryngeal speech.
Yeah, you know, I noticed that his voice is really monotone, and it's really hard for me to understand him, and it's making it hard for him to pursue his professional career.
Oh, so I see. It's not really suiting his lifestyle.
Yeah.
Yeah, electrolaryngeal speech requires a really smooth and palatable region of skin to produce the best vibration. So I guess because his skin has become really tough and leathery as a result of radiation treatment for his cancer, it doesn't really suit his professional and family lifestyle, does it?
No.
Okay. Well, without the use of the electrolarynx, we can examine other options of learning esophageal speech or tracheoesophageal speech.
Esophageal speech is a alaryngeal speech form. Esophageal speech is a natural-sounding alaryngeal speech form that requires the alaryngeal speaker to swallow air and force that air through the PE segment, or the pharyngoesophageal segment. Although it comes out in burp form, esophageal speech allows alaryngeal speakers, to use both their hands freely, which is otherwise difficult when they are using an electrolarynx.
Another form of alaryngeal speech is tracheoesophageal speech.
The tracheoesophageal puncture was originally developed by Singer and Blam in the 1980s. It is often chosen as a treatment option because it produces the most natural sounding speech. The procedure inserts a one-way valve into a fistula created between the trachea and esophagus to direct airflow through the stoma into the tracheoesophageal valve, and finally through the esophagus to vibrate pharyngoesophageal segment. After passing through the resonators and articulators, speech is produced.
You know, my husband is hesitant in learning these methods because of how frustrated and discouraged and ultimately impatient he became after using that electrolarynx.
Well, because these options produce a more natural and intelligible sounding speech, I think that it would be a really good idea to look into these for a method of speech for him. Speech is not only natural sounding, it's also longer in duration compared to esophageal speech because more air is inhaled. In one study, the difference in voice quality between tracheoesophageal speech and other alaryngeal speech forms was examined by comparing and analyzing perceptual and acoustic elements of speech. This study looks at the production and intelligibility of tracheoesophageal speech by evaluating the differences between the alaryngeal production of voice and voiceless sounds. By examining this difference, the study distinguished whether the production of these sounds was caused by myoelastic aerodynamic forces or only by aerodynamic forces on the neoglottis. The results of this study confirmed that although the speech created by the tracheoesophageal puncture is very different from normal speech, it provides better speech quality than what is created by an electrolarynx or from esophageal speech. Listeners of the tracheoesophageal speech showed high agreement, even though consonant perception was much lower than the normal speech. Overall, this research supports that although the correct perception of voice and voiceless sounds was much less than normal speech, it was a definite improvement to other forms of alaryngeal speech, and therefore a good treatment for Mr. S. The procedure is also able to be done on a variety of clients as long as they're able to maintain the mechanism properly, so I think Mr. Speech is a good candidate for this procedure. I think that it would provide not only basic communication to overcome his aphonia, but a more successful communication to help him with his family and his peers, eventually leading to a return to his profession.
Yeah, I think we should undergo a TEP.
After undergoing TEP procedure, Mr. S.'s speech improved significantly. With the new tracheoesophageal prosthetic fit into his T fistula, Mr. S. was instructed to use his thumb to open and close the openings of the T prosthetic. This occlusion allowed Mr. S. to increase his speech volume and therefore enhancing the intelligibility of his speech. Due to the success of his TE prosthetic, Mr. S decided to try a hands-free valve, a valve that did not require the constant use of his thumb. However, the hands-free valve proved to be too much effort as well as ineffective. Mr. S was then fitted with a heat-moisture exchange system, or an HME, on his TEP. An HME is a system that has a speech button for easy thumb occlusion and a filter for heat and moisture exchange. Ultimately, Mr. S found the HME system to be most effectual and beneficial to acclimating back into his everyday life as an equine auctioneer. The proper functioning of the vocal system is crucial for the effectiveness of speech. The larynx is particularly important. Severe disorders or diseases that affect the larynx result in a laryngectomy and therefore aphonia.
Mr. S.'s case demonstrates the importance of explaining the advantages and disadvantages of each post-surgical treatment option to aphonic alaryngeal cancer patients before and during therapy.
Laryngeal cancer individuals such as Mr. S, who are aphonic, find post-surgical alleviation for their aphonia through tracheoesophageal punctures and prosthetics, allowing the voiceless to communicate effectively
Once again.
To sum it up,
America, there lived a man named Mr. S. He was an equine auctioneer who had persistent hoarseness. So he went into a clinic and was told he had a lump. They didn't know the diagnosis was a carcinoma.